Good afternoon. I'd like to welcome you to today's Office of Disease Prevention Mind the Gap seminar with Dr. Hendricks Brown. Today's seminar is being brought to you, co-sponsored by the National Institute on Alcohol Abuse and Alcoholism, the National Institute on Minority Health and Health Disparities, and the National Institute of Mental Health Office for Research on Disparities in Global Mental Health. The Office of Disease Prevention hopes to bridge the gap between evidence and practice with the Medicine Mind the Gap lecture series. We choose topics that explore issues at the intersection of research, evidence, and clinical practice, areas in which conventional wisdom may be contradicted by recent evidence. It is our hope that the seminar series will engage the National Institutes of Health community in thought-provoking discussions to challenge what we think we know and to think critically about our role in today's research environment. Some housekeeping. For those of you in the audience, if you have a question, please use the microphone because we have a rather large web presence. And for those of you who are watching via webcast, if you'd like to participate in today's discussion and submit questions, please do so if you're using Twitter using the hashtag NIHMTG. You may also submit questions using our email, prevention@mail.nih.gov, and we will ask those questions during the question and answer session. With that, I'm going to bring up the Associate Director for Disease Prevention and the Director of the Office of Disease Prevention, Dr. David Murray.
Thank you. I'm very happy to introduce Hendricks Brown today. I have followed his work for some time. He is an epidemiologist and biostatistician, really biostatistician. I'm an epidemiologist, and a lot of people think I'm a biostatistician, but he's got the real credential, where I just sort of play one. We have been interested in similar design analytic issues over the years, so I'm very happy to introduce him today. He's professor of epidemiology and biostatistics at the Miller School of Medicine at the University of Miami. You can see here on the opening slide, he is director of a couple of different centers, one funded by NIMH, one funded by NIDA. He's also director of the Social Systems Informatics Program in the Center for Computational Science. He has adjunct appointments, 2 of them, at Hopkins in mental health and in biostatistics. He has, I know his work primarily in the area of innovative design for randomized trials. We were chatting a little bit beforehand. It was his work that introduced me to step wedge designs some years ago and got me interested in those. He has worked on trials related to the prevention of drug abuse, depression, and suicide. I think we're going to hear some about that today. He's developed new methods for synthesizing data across randomized trials. He also applies system science and computational methods for implementation of research. So let me please introduce Dr. Hendricks Brown.
Thank you, David. I really appreciate those kind words of introduction. This is really a thrill to be here and to be part of this series with the Office of Disease Prevention, which I think is incredibly important for us in terms of moving an agenda forward. Today I'm going to be talking about health disparities, if I can make sure I get this right. Particularly around what we're going to be calling scientific equity. And it's a new term that we've been using in here. It's certainly influenced heavily by a lot of my colleagues at the University of Miami who have been working on Hispanic health issues for a generation. But it also goes back to my early days at the University of Chicago, where I was working on the Woodlawn Project with Shepard Kellum and a number of other people in here with African American populations in here. And the idea of this is that we really need to take a very careful look at what kinds of information we're collecting. What is the broad picture of the scientific agenda around addressing disparities in minorities and other populations? I wanted to start with acknowledging the 2 grants that I have that NIMH has funded this collaborative synthesis of trials on adolescent depression that I'll talk about mostly today. I'm going to spend a fair amount of time talking about some of the issues that we've learned in here. Also NIDA for the Center for Prevention Implementation Methodology for Drug Abuse and Sex Risk Behavior. And also for 25 years of support from NIDA and NIMH around the Prevention Science and Methodology Group, which is a network of people that we've had in collaboration across the country and some outside the United States who have been working together around not only developing new methods, but also applying them in settings so that we can use the maximum knowledge we can possibly gain from these kinds of studies. I also wanted to point out the co-authors that are on this project in here. Tatiana Perino, I'll mention a couple places in here that she's been leading a lot of the work on data synthesis on this project, Hilda Pantin and others in here that are both at the University of Miami, but also Guillermo Bernal, University of Puerto Rico, George Howe, Velma Murray, and Erwin Sandler on this particular one. But this is a small set of all of the collaborations we do. So I'll give you more people at the end of this one. I appreciate all of the work that everybody has done because this really is truly collaborative. So here's the kind of outline I wanted to do. I think it's important that we take a little bit of time talking about health disparities itself. What are they? What does that mean? What are the levels of health disparities that we see in the United States? I'm going to focus on this application and all about youth and young adults, although we could go in and talk about the effects of adults as well. And the areas of outcomes that we're going to be interested in here is what we're going to be calling, borrowing from the recent IOM report in here about mental, emotional, and behavioral problems in here. So we'll talk a little bit about prevalences and differences in healthcare as well. We'll also talk about this word scientific equity and what it actually means in here. How do we use that to help and support achieving health equity in here? Third point in here is we're going to talk about some specifics about the different ways of using scientific equity in different problems in here. One of the areas we're going to do is looking at ways to synthesize findings across multiple trials in here. A second point, which may come up more in the discussion, I'm just going to allude to it mostly in here, is about implementation research as well, because those are the key problems that are challenges for the next phase of work in here. And then finally, we'll do a little bit of summarization in here and look at what NIH policies look like right now and how they might be relevant to this issue. So, starting off with defining some of the terms around disparities, inequities, and inequalities. The first thing is if you start to look at what the literature is, the first thing you see is a lot of ambiguity. There are at least 11 different definitions of health disparities in here. My favorite one, I think, right now is probably the CDC one, which you're welcome to read in here, but it has to do with differences in health outcomes and the determinants between segments of the population. Is defined by social, demographic, environmental, and geographic attributes. In other countries, the existence of disparities is indicated as a health inequality simply by the existence of it. And so that's a much more proactive kind of role in here. In the United States, there is a legal definition by public law. The definition of a health disparity population is given by a significant disparity in the overall rate of disease incidence, prevalence, morbidity, and mortality or survival rates in the population as compared to the health of the general population. We are going to be looking at issues with different race and ethnic minorities in here, particularly African Americans. I'll talk a little bit briefly around American Indians and Alaska Natives, but also Hispanics as other populations in here. I won't say too much about low socioeconomic status or rural factors in here, but those are important as well. I'll give you a little bit of indication from some of the data about those as well. So, question about how do we move towards health equity? So the words health equity, I think, really are very positive. It doesn't focus on necessarily the differences in here, but it focuses on the solution. And that's the point that we want to make in here. So moving towards health equity and also health care equity, the actual services that are provided in here. So health equity is defined by Health and Human Services as the attainment of the highest level of health for all people. And I'm not going to read through the definitions in here. I'll let you read them at your own. But you can see that there is a real sense of social justice behind the ideas of health equity. That American citizens and people living in this country should deserve the best quality of health that we can provide in here. If we go talking about what the actual inequities are around U.S. youth in here, around mental, emotional, and behavioral health, the term mental, emotional, and behavioral health has been used by the Institute of Medicine in 2009. It does leave out an important dimension in here, which has to do with cognitive functioning, which I think is an important one to include as well. But what we're talking about is diagnosable disorders, including depression, anxiety, also schizophrenia and other areas like that, as well as problem behaviors, and drug use and abuse, antisocial or aggressive behavior, and violence, for example. Lots of description is available on the web. CDC has a whole website for looking and identifying health disparities in the 2011 report with a reference down at the bottom of this one, noting that it's been a priority for CDC as well as for SAMHSA as well as NIH for addressing issues around health disparities here. I'll give you a couple of important examples in here. I think you have to start off with this one. HIV infection by race and ethnicity is totally intolerable. For African American females who are either youth or young adults, their rate of infection is 11 times that of white non-Hispanic females and 4 times that of Hispanic females. For African American males, it's 7 times as high as it is for white non-Hispanic males and 3 times as high for Hispanic males. And that's a national priority that we address it. I do think as we start to think about what those strategies are, which I hope will come up in some of the conversations today, that some of those solutions in here are going to be innovative. They're going to have to be doing something different than what we're addressing right now. But a lot of the other rates in here that if you report them simply at a national level with very broad categories really don't pick up the real differences. And you do have to take a look more deeply at those rates and understand specific combinations of age, for example, socioeconomic status, immigrant status, etc., in order to be able to look at it. So I'll give you a couple of examples. Here's one for substance use or abuse. This one comes from the Monitoring the Future studies for 10th graders. And you can see that the line with 1 over here corresponds to a comparison rate with non-Hispanic whites. And you can see that the rates for African Americans in the blue line in here is almost always below that for the reported rates for white non-Hispanics. For Hispanics, it's about the same for many of the outcomes in here, but only a couple of them seem to be a bit higher overall for Hispanics. And again, these are national rates in here. When you start to look at them by other subgroups in here, really important differences start to appear. Suicide rates in here are dramatically different by different groups in the population. Whites, particularly males, have much higher rates than others, except for the population of Native Americans and Alaskan natives. Those rates you can see in the dashed line that is elevated very high among the younger youth and adults. And then it goes down and decreases dramatically, even way down below the continuing upward level of the rate for white Americans. So you do need to take a look at the distinctions when these rates are in fact changing. Here's an example for suicide as well. Not only is there a large difference by region of the country, where in the West the rates of suicide are much higher than they are overall, but this displays a picture of the level of rurality. So these are 9 categories overall in terms of the level of urbanicity to rural communities. And what you can see is a very consistent pattern for everybody except in the South, where as you go to higher levels of rurality, that the rates of these increase. And this occurs even within states. So there's something very systematic about this in terms of rural rates of suicide are higher than they are with urban settings. This is an example of a wide difference in the rates for Hispanic populations. The time at which individuals come over into the United States shows a large variation in the effects of the prevalences of substance use, for example, and other psychiatric disorders. If you think about first generation in here, foreign-born is the comparison group in here, and then compare it to second generation, which is individuals where the kids are born in the United States, and then the third is when the parents are coming over in here. The rates of these outcomes often vary in the sense of both illicit drugs and binging and suicide attempt. It's very clear that the rates are higher the longer the people are in this country, unlike what you might expect. And this is the Hispanic paradox. It also shows up for adults as well. It doesn't show up nationally on depressive symptoms, though, as much as it does here. Okay. There's a lot of other issues besides just the rates that are important differences in here. Healthcare access and quality are incredibly varying as a function of minority status, for example. The IOM book in 2003 documents a lot of the differences in here, that race is still predictive of poorer outcomes, poorer access to care, even if you control for SES and age and severity of conditions as well. And that's a major factor in here in terms of poorer outcomes among a large group of individuals who are minorities in our country. Maggie Alegria and her colleagues have talked about the effects on substance use disorder for African Americans in here who receive less informal care, as well as specialty care for drug use. It also is affecting Hispanics and Haitian youth as well. Okay, so I wanted to turn now to, after just an introduction of those topics in here, to scientific equity. Scientific equity, we think, is a strategic approach to try and address these issues of health equity. So what do we mean by scientific equity? It's the equity in the amount of scientific knowledge that is produced to understand both the causes and solutions of health inequalities. So what we're talking about is do we have enough scientific knowledge that we're putting together to be able to address these? And also, a parentheses in here is that it's not just the production of that information, but it's also the actual use of that information. There's a lot of data mining that needs to occur in here. Maybe a better term is what Naiwa Duan calls data farming. That is much more strategic use of the data that's out there to just get as much as you can out of it. And so it's really the application of that knowledge as well that's important in here. So while there's a substantial amount of data to indicate health inequities exist in here, we need additional research data to tell us what effective strategies should be used to try to guide our work on this. Here's a couple things that scientific equity can be helping us to answer. Why and how does a condition develop in the first place? What actions can be used to prevent the condition from developing or help them resolve or ameliorate it once it does develop? And what service systems are needed to prevent or treat that condition? Particularly is the variations that occur across minorities and other groups. So, we think it's important that we have to achieve scientific equity if we're going to have any chance of trying to address the health inequities. If we don't have the scientific knowledge available in here, then we're not going to be able to go forward. So that means trying to understand which interventions are effective, but that's a very broad kind of category in here. We need to know beyond that. Do efficacious interventions or effective interventions work equally well for all groups? If we can't start to get that kind of answer, we're not going to be able to address inequities in here. So the lingo that people use in here has to do with moderators and mediators. Moderators have to do with what interventions are effective for which subgroups. Mediators have to do with the mechanisms. Why does an intervention work? And there's some beginning information that people have about these kinds of topics in here, and I'll give a couple of examples. If you think about what the strategies are trying to remove these disparities, there's a lot of different approaches that people have made. George Albee, who was one of the fathers of prevention, really focused in his later part of his life around issues of racism, sexism, poverty, stigma, etc., and thought that those were the really primary driving forces. They certainly are important in here, they clearly are. One of the questions is how much opportunity do we have of making direct impact on those particular broad characteristics in here. But in the meantime, we've learned an awful lot about what prevention programs work. The IOM report in 2009, as well as many other places in here, have demonstrated that there's lots of prevention programs that work across the lifespan, across specific populations. And we're now in a patchwork area of trying to integrate all of that material together to see under what conditions do things work and under which conditions can be used. Strategies for delivering prevention programs or intervention programs range all the way from genetics and biology, the kind of work that Jean Brody is looking at, and looking at variation in genetic factors associated with prevention programs in here, to target specific behavior or social environments, to physical environments, or even the virtual environment that are useful. And it is important to note that these are multifaceted kinds of strategies that we're probably going to need here, because if you look at what happens to minorities, they have often a combination of a range of risk factors that are going together. For example, with HIV, the susceptibility for HIV, the prevalence of the HIV virus in African American communities is higher than other ones, for example. And there's low access to health care, there's more discrimination, institutional racism, etc. So when health interventions can improve the population's overall health, they also have a possibility of actually increasing health inequity. And this is a result that Laurent pointed out in 2012 in here, that sometimes when you deliver an intervention, that the intervention is not taken up equally by all populations in here. So a good example of that is intervention-generated inequities is what they call that. Smoking bans and things like that in the workplace often have higher impact around those with higher socioeconomic status and not as much on lower socioeconomic status. So there are plenty of examples where there are differential subgroup differences in response to interventions, preventive interventions particularly. Cardamil and others, for example, looked at the Penn Resilience Program and found that this school-based prevention program for focusing on depression had impact, beneficial impact on Latino children, but it did not have impact on African American children. So it raises some of the questions about what's the mechanism of that. Another example that might be useful in here to take a look at is Nancy Gonzalez's study of bridges. It's a preventive intervention in high school for Latinos and their families. It found that there was differences in here in terms of the mechanism of intervention. So what it found is that for those families which preferred to get the intervention in English, they showed higher increases in maternal monitoring as the mediating factor towards later outcomes. But they also found that in Spanish-preferred speaking families, they found reduction in maternal harsh parenting, and that was the one that mediated. So what we're looking at is potential variations in these kind of mediational pathways that we need to be able to identify and discern. So this is just one example. We really haven't looked very much on this one. So the question now is, how do you look? Or what kinds of areas would you take a look at in here? So I'm going to briefly talk about two ways of looking at this one. One is this collaborative synthesis idea around randomized trials, and the second has to do with implementation science, because I think those are the key factors that are going to be useful. So if you really start to think, what are the reasons why we are not being able to remove the health disparities in our country the way we would really like? I think there are three possibilities here. And if you just start off and say, well, maybe we just don't know that these disparities exist. Second is that maybe we know that they exist, but we don't know of any successful interventions that we could use. And the third question is, maybe we don't know how to implement those evidence-based interventions. And so I'm going to take us through the little logic associated with each of those three kinds of areas in here. The first one's pretty easy to see. Do we know about disparities, and they exist? We certainly gave a good deal of examples in here, and we could do hours and hours, and people do courses on origins of disparities, et cetera. So that really is, that's not the reason why we're not successful. So let's go to the second one in here. Do we know successful interventions? Okay, so here's three possibilities, and we're going to look at what prevention programs or strategies might work for Hispanics. The example I'll use has to do with this NIMH project of looking at depression, preventing depression in here. And we're going to take three possible ways of looking at it. We could do things like, let's take a single prevention program that's only specific to Hispanics and take a look at what that effect is of that intervention. The second one is to take a generic prevention program that is not specific to Hispanics, but look at what happens to the Hispanic subgroup in that trial. And the third one is to say we're going to look at the efficacy or effectiveness for Hispanics by taking population, combining trials that have Hispanics in them, but they're not the only individuals in those studies. So those are the three things we're going to take a look at in some level of detail in here. So the first one is again, we're trying to say, maybe we just don't know that there are successful interventions at all. So number one in here, let's take a look at what prevention programs are done only specific for Hispanics. If you look at the IOM book in 2009, there's a table at the back of it that looks at funded trials from NIMH, NIDA, and NIAAA that are specific to African Americans and Hispanics. And what you find is, of all of the trials that are out there, about 5% of those are specifically focused on African Americans and about 10% for Hispanics. That's certainly less than the general population of those. And so we think of the knowledge we are gaining about specific interventions, specific to those populations, is underrepresented here. So we have too few of those trials. But it's also that we have too few that are evidence-based, that we really know that they work in here. The rate of new prevention trials for disadvantaged minorities is certainly not keeping up with the population. But even if that was the percent in the general population, it wouldn't be sufficient. Because we have a smaller number of trials in here, we still need to have sufficient numbers that give us a large fraction that are going to be successful. And we wouldn't expect that differs across intervention by ethnicity in here. So we're not gaining as much knowledge as we need to address these issues. Okay, so we're now going to go to these other second issues in here. Testing a generic prevention program in a trial restricted to a Hispanic subgroup. Okay, so here's the next step in here. In 1994, NIH identified guidelines for inclusion of women and minorities and children, especially in phase 3 clinical trials, with very logical reasons in here, because much of the work, particularly it was focused around heart disease, was only around men, and women were dying at that time because specific predictions of who was at risk for a heart attack was not even identified for women the way it is for men. This is data that came from a 1996, let's see, I guess the final report in here is 2010, about phase 3 clinical trials. It was about 630 in 2009 and 2010. The number of subjects altogether in these trials was 600,000 to 700,000. African Americans made up even more than the general U.S. population in this one, and percentage-wise, but Hispanics and Latinos were less, substantially less than this. I suspect a major reason of this was because the language differences were an important part of this one. So we're going to take a look at this one and say, well, what would you get if you took these generic prevention programs and then focused only on the Hispanic subgroup to see whether there was enough information in there to give you an idea. Here's what happens. If you take a generic prevention program and you do it with a single randomized trial, the typical trial still is about $500,000 a year. It's getting more costly to do, and the number of people that we're getting into those trials each year is less because of the cost. So the proportion, unless we're getting higher and higher proportions of minorities, we're probably going to have very few of those individual trials who are going to give us sufficient information for minorities. Statistical power in here for the impact on minorities and moderation is probably not going to be improving over time. If anything, it's probably going to be decreasing. So what we've got is a single trial is probably not going to help us, particularly if a lot of them are $500,000 a year, and that's the maximum. So we're really going to this last part of it here, of examining how can we synthesize findings across multiple trials. And that's the place that we think we can really make a huge amount of gain. And in fact, we probably have sufficient data already to be able to make some of these gains. So the Collaborative Data Synthesis Project for Adolescent Depression Trials, or the Synthesis Trial in here, is funded by NIMH, and my colleagues George Howe and Hilda Panton and Tatiana Perino are the key leaders on this one. It has 3 aims. One of them is to develop new statistical techniques for synthesizing findings, particularly around mediation and moderation as you integrate across multiple trials. We're talking about individual level data. We're talking about how do we deal with differences in populations across trials, across the intervention, across the design of the study. Different time points, for example, and outcomes. And those all are technical problems that are more complicated than the traditional meta-analysis kind of problems in here. In addition to that methodologic aim that we have, our focus really is on the application of those methods for depression interventions in adolescents. And we decided we were going to include both prevention and treatment in those. We have 40 individual data sets. We're in the process of collecting that. We've gotten most of those so far. And we're looking particularly around moderation and mediation. The third aim in this one has to do with scientific guidelines for conducting the next generation of intervention trials. Sure, go ahead, David.
You note that there are differences in populations and the interventions and the trial designs and these studies that you're trying to pool. And one of the trial design differences that I think is a real challenge is Some studies are randomized at the individual level, some studies randomized at a group level. And is that one of the things that you've worked on? Are we going to hear a little bit about that as we go along?
So the question really had to do with randomizing differences at the individual level versus the group level. It turns out that in this study with NIMH, we're only looking at trials that are randomized at the individual level or very, very small groups. So that's not a specific area that we've been looking at yet. But along with a lot of other projects, this is a critical piece of how do you synthesize when the designs are quite different. Particularly when you're looking at longitudinal design, some of them with a randomized trial design, some of them might have an active intervention, like in an implementation trial design, or that they have a control group as well. And Liz Stewart has done some of the work related to those. But those are open questions, completely open questions. Here's a couple of papers that we have. I'll just mention the top one in here because of the emphasis on collaborative data sharing. What we've decided in here of trying to work together on getting these data, which are from randomized trials. It's a bit different than getting data from longitudinal studies. Who owns the data? Who is responsible for the integrity of the findings of those data? What people have already published on those data and need to continue to publish are all big issues of working together with this. And so instead of automatically handing over these randomized trials into a registry or into a repository, many of the interventions that we're looking at with behavioral interventions, people are not ready to do that. And so it becomes quite difficult to work out those details. What we decided is that we wanted to do it collaboratively. So partners using a CBPR kind of approach, we said, let's go to the people who are working with those data sets. They have them approved at their own IRBs. We want to get the data in a de-identified form for us to be able to combine together and integrate together. And a lot of those details are worked out in this first paper by Perino et al. That's coming out in Perspectives in Psychological Science. And maybe we could talk about the mechanisms on doing that later on. But we think in this time and age, before we get to the actual data sharing that the NIH policy says that they're going to do, and actually have people share their data in a much richer way in here. Lots of people have already had data sets that have said, we're precluding you using our data for any other purpose than what we've already said. So it's been difficult to work out a lot of those details from existing data sets. But as time goes on, I think we're going to get a new, better policy, and people are going to be sharing their data much more than we have right now. One other comment about this one is about the collaborative nature. We think that our third aim in here is what does the future look like for implementation, for randomized trials? And that people who are collaborating on this would be partners in developing how do you make sure that the data that is being collected has maximum use as you integrate across all of these different trials together. So it's not just single trials, one at a time, that we can't quite figure out what to do with, but we can try to find ways to collaborate those. Okay, so we're talking about combining individual level data across these to look at different impact on different subgroups in here. One of our trials in here for prevention has to do with the effects of parenting-focused interventions that are not specific to race and ethnic minority groups. And we have 7 of those right now that we have data at hand, and we can take a look at that to see whether or not the intervention looks successful for Hispanics versus not successful. So in this data set for 7 prevention trials, the outcomes actually are between 14-month long to 2 years that we've been looking at in here. Over all of these trials, each individual trial has sometimes as little as 8 Hispanic in it, to a maximum of 42, but when you combine them together, you get 159 individuals who are Hispanic. And similar with African Americans, and white non-Hispanics actually has substantially more in here. So this is the result of a multi-level growth model that we've been doing in here, where we've looked specifically at the impact of these interventions, these prevention trials on depression. Now, it turns out that almost all of these outcomes, all these trials were designed initially for drug abuse or HIV sex risk behavior. Very few of them were specifically focused around depression, but they did collect depression data. Many of these had never been published, and if you only had a handful of cases in here of Hispanics, you'd never have any chance of writing anything else that would be even meaningful to be able to collect information about the effects of this. So this is new types of results in here that we think are at least a first cut at what kinds of impact these interventions might have. So among Hispanics, the effect of this intervention on 159 people is a negative effect of the slope of that regression coefficient over time, meaning that there's beneficial reduction in depressive symptoms over time that is significant at a 0.01 level for that analysis. For African Americans, the data in 125 doesn't suggest that they're significant in here. It goes in the same direction. And in fact, if you look just at the magnitude of the effects, these are on essentially the same kind of scale in here, that the effect looks stronger for Hispanics than it does even for whites. That was based on an initial study that we did where we went to all of our friends and relatives who had data that we knew about. But then we did a farther search through the prevention trial literature. And we broadened the scope of the kinds of interventions to look at that. We found another 66 additional trials around adolescent depression that we thought matched our criteria, had minimal levels of intervention trial design that was rigorous in here, and could be used to evaluate the effects of this one. If you look at these, the trials, some of these trials were outside the United States, but the trials in the United States had 620 African Americans or blacks and Hispanic population in here, over 1,000. So that's sufficient for us to be able to take a look at much broader kinds of questions, including mediation and moderation that we have here. So we think that the data exists out here for answering some of the many questions we have. We just have not assembled that. And it takes a while to do that, but it's important to do. I do have an example for mediation and moderation to take a look at in here when you can combine trials together. So here's an example where we took 3 randomized trials, all from the same group. It had the same intervention, but done on 3 different kinds of populations in terms of level of risk to begin with. So these are 3 Familias Unidas randomized trials. When you combine them together, what we found is that there was an effect of both moderation and mediation in this one. But you didn't see that until you combine the data together. And just remember that this was designed initially for looking at drug use and sex risk behavior. It wasn't designed for depression, but we can learn from these things. And what this says is that when there's low family communication at baseline, there's intervention benefit. And that what happens to explain that benefit is that the intervention actually improves parents' communication, and once it is improved, it benefits the results of here on depression. So that's what this last summary is. It had about 721 adolescents that were combined together. And we found very definitive kind of work on here in depression. It turns out to be the same mechanism we saw with drug abuse. I did want to give you this point about there are, in fact, successful prevention programs in minority populations that are specific to those populations. So even though there aren't many of these, there are a couple of them. Familias Unidas that I just mentioned in here started off with 100% Hispanic population. It had effects on drug abuse and sex risk behavior repeatedly, but it also showed on depressive symptoms and looking at particularly mediation and moderation effects when we combined the data across studies. We never would have found it had we not been able to combine the data. The Good Behavior Game is a first-grade intervention that was focused mostly on inner-city urban populations mostly African Americans. Now it's being tested in some Latino populations as well, and it's also being part of SAMHSA's rollout of intervention in 21 school districts. Here's a set of outcomes that both of these have. If you look at what the outcomes in here, Familias Unidas has impact both on drug use and abuse, on risk behaviors in terms of condom use the last time, and unprotected sex, combine drugs and unprotected sex together, as well as depressive symptoms for Familias Unidas, and also for suicide attempts for the good behavior game. So these are major effects in here that are possible to do. We think that there are some useful interventions in here. So when we go back in here to look at this one, let's now move to the last part of this one. Maybe the real reason is that, well, there are some interventions out there that do work, but we just don't know how to implement those. I think that's the next stage of work. And that's the big unknown in this next field of trying to do this one. Because if you know that interventions might work in here, you still need to deliver them effectively in populations. So this is a picture from the Institute of Medicine report, Stages of Implementation Research, on looking at what are the stages of research questions around dissemination and implementation research. Usually you bring that into 3 or 4 different categories. The adoption phase is how do you get communities to adopt an effective intervention? Implementation with fidelity, how do you do it with fidelity? And third, how do you sustain that or increase it and scale it up over time? So those are the next sets of research questions. I do think that it's important to really reframe and focus our attention in these areas. Harold Pearl, who's here, I'd like to quote in his 2011 paper in here, which I think has a great title, that we may be addicted to discovery, but does that quest for new knowledge hinder practice improvement? And I think those are the next stages of research scientists in here. We need better tools. We need to have a partnership in here, and we need to make it relevant, the science relevant to practice. If we're ever going to be able to reduce these disparities in here, and if science has anything to say about the actual reduction of problems, MEB problems in our society in here. That's the focus of our NIDA-funded Center for Prevention Implementation now. And I'm going to just mention and close with one tool that we've thought has been useful in here at this early stage. Has to do with randomized implementation trials. This is used specifically to test to see whether one strategy or another can change the speed, quality, and quantity of implementation of an evidence-based program. And I'll give you an example of that one. This is a randomized trial where you were testing head-to-head 2 implementation strategies, but the intervention itself is the exact same intervention. So we'll take a look at this one. It turns out that this was done in 51 counties across 2 states, looking at how fast, how well, and how many children were served in a child welfare intervention called multidimensional treatment foster care. And this is the picture. If we were doing an effectiveness trial of the multidimensional treatment foster care, MTFC, it would look on the left side. What we would look at is comparing impact on youth by looking at those that get randomized to MTFC versus the control condition. And then everything about the implementation of that MTFC is all in the background. So that's all the stuff in red that we usually don't even talk about. We may not even write about it very much, but it's all of the stuff that really depends upon what we get for impact in here. And we can do this in effectiveness or efficacy trials on the left-hand side. Effectiveness still, we typically don't put all of the knowledge about what we are actually implementing in here. What we're doing in here on the looking at whether or not 2 different implementation strategies change the outcomes of the MTFC intervention is we're doing randomly assigning counties to either the standard version of implementing in that county versus one that's this community development team approach, which implements at the county level. A community development team approach uses a peer-to-peer network where counties get together and work closely together, so we have to take into account the clustering of counties in this analysis as well. So let me summarize this one by looking at questions about how do the current NIH strategies support scientific equity. If you look on the NIH website, the 2008 report on the science of eliminating health disparities, I think is one of the latest versions that I think is a useful document to tell us what it is. And one of the steps in here is to, quote, increase the number of participants in clinical trials from racial, ethnic, minority populations and other health disparity groups. That's true, but there's a but to that one. I think for scientific equity, we need to make sure that we do more than just increase the numbers, because we've been doing that for a long time, since 1993, and we still haven't gotten enough information together to be able to combine to understand what those are. So we have to have sufficient number of trials that are restricted and limited to specific minorities. We have to have sufficient numbers of minorities in trials, and then I think that the main part, I think we're going to be able to benefit in hard times such as ours in terms of the budgets, is to be able to synthesize findings that combine minorities across trials. Secondly, directly related to this one, is the need that NIH identified to improve the research data collection systems, enhance data quality regarding health disparities, and develop uniform data systems to facilitate strategies for the elimination of health disparities. The synthesis methods we're developing here are, I hope, would be a first generation. I think that we're tackling some really complicated problems about what happens when the measures are not identical to one another. We do what we call harmonization in here. But if we had measures that were similar or identical, we would be in much, much better shape in this field than here. And so we need to have some abilities to try to bring together a field which is moving disparate ways at different times in here. So finally in here, the only ways that I think we're going to be able to address these problems is a combination of things with research, policy, practice, and methodology. This is the group of people that we have in our NIMH synthesis project. This is a group of people we have in our center in here, including those that we are partnering with SAMHSA. So thank you very much. Be happy to take comments or questions.
Hi, thank you so much for your engaging talk. My name is Suyeon Lee. I'm with the Office for Research on Disparities and Global Mental Health. I was really excited to hear about the data synthesis, the collaborative work that you're doing in combining data. And I mean, you talked about the harmonization of the measurement. And one thing that I was really curious to know more about was each study has its particular internal and external biases, issues. And so when we're analyzing data, how do you take that into consideration? So that was my first question.
Great question. So I don't know if everybody can hear that. So the question is how do you take into account some of the internal and external biases of each of the studies when you try to integrate those together? We have I think we have one thing we've been trying to do is trying to get collaborations with the people who have collected the data, who run the trials. What we've called tacit knowledge is a critical part of the study. And it goes beyond just what did the measures say, how was it collected, but it addresses those same kinds of questions that you have. So for example, one intervention trial that I know uses a very well-known professor as the control group intervention. And he delivers lectures on that. And so if we don't take into account the kind of effect that that person might have in terms of making changes in the developmental course of those individuals and compare it with somebody who's not, to a less active control group, I think we have some problems in here. The part that I think we need to do is make sure, especially with randomized trials, is that we do this in partnership with the people who run the trials. I would hate to really work without that kind of collaboration. So that's kind of the first level, but maybe you have other suggestions.
Well, I mean, it would be great to have some systematic ways to account for those things. And so, I mean, I look forward to hearing more about the guidelines that you publish after that. The second question was, so it's one of the advantages of collecting these data and combining together is that you're better able to capture the mediating and moderating variables. And so I was wondering, I mean, so we have these like clinical trials, and I mean, looking into these implementation pathways, whether, I mean, these mediating and moderating variables have the potential to inform what kind of evidence-based practices could be implemented well or not, and what the steps could be. And I was wondering if these, you know, traditional clinical trials and the methods that they use and the quantitative capturing of these things are working well, and whether, you know, I mean, in your experiences, what are some other things, areas that are usually not being captured that should be part of the standard measurement as part of the randomized control trials?
That's so the question of what other things could you capture in here. I think there's two things come to mind. One of them has to do with the distinctions between efficacy and effectiveness trials. And I don't think those words are exactly the same, used exactly the same way across different institutes, or especially with NIH, I think has generic kinds of terminology of this one. It's not the same with education, for example. I like to distinguish between the two in terms of if somebody's not delivering the intervention as expected, can you get rid of them or retrain them or not? So efficacy studies, you can do that. Effectiveness studies, you may be only able to use the people in the host organization, that might be a school or community setting for prevention, or therapists that you can't get rid of. They're the ones there. And I don't think we do a very good job of distinguishing those kinds of characteristics, exactly who those things are. The second thing I think is really relatively weak in here is the information that we get about fidelity. What are the fidelity and monitoring and feedback systems that people need to use to be able to deliver an intervention with the level of precision that is required? And I think we're now in the process is one of the big, huge issues, I think, in implementation, that we need to get a better way of defining exactly what's happening in those.
I also have several questions, but I will ask one and then let others do that as well. The randomized implementation trials, the diagram that you showed, the design that you showed, the two arms in that would differ by virtue of the implementation method that's being used, but they're both delivering the same intervention. So what if you find no difference? How do you know whether that's a intervention failure or really no difference in implementation?
It's a good question. Is it, if you find no difference between in a randomized implementation trial, it turns out that the process, and what we're looking at is outcomes that are process outcomes first. And those are mostly what you can do in those randomized implementation trials. And in fact, it's more difficult to look at outcomes that are on the target population in those randomized trials because the kids ultimately are not randomized at that level. Okay, so what we're looking at is randomizing at a county level to see whether the process itself changes. That's very measurable. And that, I think, is worthwhile to try and take a look at directly as a mediator to ultimate outcomes. One of the things that I think people are looking at is look at the relationship between the implementation of that intervention and the ultimate outcome from previous research. And so people are often piggybacking on the existing randomized effectiveness trials to try to see whether that kind of impact would be demonstrated but based on previous work.
Hi, how are you?
Good, Ari.
I was really intrigued by what you were talking about in terms of intervention-generated inequalities. And I was wondering whether you have thoughts about ways that researchers can design studies to ensure that that is addressed in the front end, if you will, of efficacy testing.
Well, that sounds like a perfect program announcement, doesn't it? I don't have a, I mean, I think this is one of those issues. It's a little bit different than sort of the standard approach that we've typically taken for looking at iatrogenic effects. I think it's something which we really haven't put our attention to, and I think it's worthwhile doing this. I do know that when I look at randomized trials, I always look for iatrogenic effects, because I don't believe that any particular intervention is going to work for everybody, and sometimes it could be harmful. We don't deliberately look at that. I do think that one of the things that, if you go to the Society for Prevention Research meeting coming up in May, Amy Goldstein, who is our project officer for the Synthesis project, focused a number of us on this question of who are non-responders to interventions that are focused around depression. And so that, I'm hoping, will give us some better clue, but we generally don't have our eye on that at all.
Hi, I'm Janine Clayton from the Office of Research on Women's Health. It doesn't sound like it's on, but let me ask you a couple questions. So the first one's not related to women's health, it's related to the way that Hispanic ethnicity was treated in your data presentations. So you're aware of the OMB categories for race and ethnicity, and Hispanic is an ethnicity, and
Yes.
the way that the data are reported in the NIH data, which you provided there from the comprehensive report, separates ethnicity out. How do you incorporate that into your work? And let me give you the second question, because you might want to include it together.
Yeah.
And that is the intersection of sex, gender, and race ethnicity. We're particularly interested in women of color as an understudied and underserved population, and so that's related to that.
Absolutely.
I'd love to hear your thoughts about it.
Yeah, so all I'm saying in this initial analysis, it's very crude. I think it more is, what I was intending to do is to say, is there any data out there that gives you some suggestion? I don't think this is by any means complete. Certainly looking at gender effects, which by only adding in a main effect in this analysis that I did here just as illustration is very crude. But it also was a lot of other factors that were not included as well, including the generational status and for the populations and you know, that are just mixed together in here, and it's not the same. So I do think what we have planned in here is much more of a strategic way of dealing with multiple levels of adversity and bringing them into focus one at a time, and then in combination to the level of extension that we can get to. And I think we've got a long ways to go yet. So that's my short answer to an apology to what we were able to get to so far.
No, my comment wasn't a criticism. I think you did a really nice job, and this is a very, very important way of looking at information. The synthesis issue and harmonization is a huge issue, and as you aptly put, the times are particularly constrained, and we're absolutely all going to have to do more with less.
Right.
So I thought I really enjoyed the presentation. I would say that I wouldn't consider, as being a woman, that sex gender is a level of adversity, which is the way you just put some things. So I would just encourage you in the future that that might not be exactly the way you might present that. It is, you know, gender and presentation of being female in various circumstances
Right.
Or where you might present that.
So taken.
Hi, Hendricks. As you know, adaptation of prevention interventions is a big issue, especially with some of the service delivery agencies who feel very strongly that evidence-based interventions that have been tested at a global level are really not appropriate for some diverse populations, specifically African American rural populations, American Indian populations, Alaskan Native populations. This seems like it would be an approach that would at least harness data to give some sort of an answer to those concerns. How would you respond if you were put on the spot by one of those agencies?
Well, I think the first part is, and we haven't done this yet, but I think the first part is to identify what the gaps are. And I think we've got plenty of gaps in this whole area that I think need to be identified first as a broad scientific strategy of where we're going to put our focus. And I think that the combinations that we're looking at are challenging to try to identify which ones are the most priority ones to address in here. But I think if we don't put those on a map, I don't think we're going to be able to get very far at all. I do think that the issues that you're raising about what is not just the level of fidelity, but what is the level of intervention that is delivered in here, and as it gets modified and adapted, is the next generation of work that we need around implementation. And we're looking forward and partnering with people to understand how that happens and what the next process is. Gene Poduska, for example, has been funded to look specifically at adaptation of the good behavior game, which we're looking at as well. But I think this is a big generic issue, and we're going to need to take the specific knowledge of individual interventions and then learn from those to try to get generalizable knowledge about what could we make as inferences in a broader setting across different populations and across different interventions.
One of the challenges in doing a synthesis, as you've done, is that you're essentially putting a lot of different studies together, looking at effects of treatment versus control, and an assumption that underlies that is that all the treatments are the same across all the studies. You're not distinguishing among them. It's just simply treatment versus control. Another approach to putting projects together is to do something like a meta-regression, where you code the interventions across all the studies, code up the elements of the intervention that you think are important. They may very well vary across the studies that you're doing. And then in your analysis, you're looking at effects of those various pieces of intervention rather than just intervention versus control.
Right.
Can you talk a little bit about how that differs from what you're doing, whether it's something that you anticipate doing going forward? I know NHLBI is planning a workshop this fall on campus on meta-regression, and I'm seeing it used increasingly.
Right. In the paper we just had in Prevention and Medicine that came out just this year, we did focus around two parts of that question that you were asking, David. One of them is, if you think about the variations across trials, a part of that is accumulated by looking at random effects at the trial level, which would combine characteristics of variations in those interventions, but without specifying anything particularly about those interventions. You can put in dosage, for example, as a characteristic. We're not totally sure that that's going to be a really good one, and I think we're just in the process of trying to learn whether or not we have any kind of differences. Even if you go back to the heart disease prevention trials, though, of looking at aspirin, And you look at what we learned when people did meta-analysis on those, the level of dosage of aspirin in those trials was, I don't know, something on the order of a variation of 5 or so, 5-fold. And nobody really analyzed that data either. So I think it's as common in meta-analysis as it is in sort of this issue that we're having in here. But when you can get a meta-regression kind of variable in here and it does work well, you really get a much better efficient result in that.
It would also let you include more studies in a given analysis.
Yes.
So when you're trying to identify studies where the intervention is similar enough that you can essentially pool them, even if you're including a random effect per study, then it limits the number of studies that you can include in a given analysis. If you're willing to allow greater variability in the intervention because you're going to code components and look at the effects of those different kinds of components, it allows you to increase the number of studies in a given analysis.
That's right. It definitely will work.
Other questions? Questions from folks watching on the web so far? Not yet. Other questions from the audience? Then I'll ask another one. In your collaboration, you were reaching. I'm intrigued by this. You were reaching out to folks in order to get their individual level data, and I can certainly understand the need to do that. They're not just going to mail it to you and say, "Do whatever you want." Did you run into any IRB or ethics issues because the participants in those studies consented to participate in those studies? They didn't consent to participate in a synthesis analysis that you're going to do further down the road.
Right. We ran into lots and lots of IRB issues. That particular one, which we thought was going to be an important one in here, was really not a big issue for us. I don't think of all of the 40 trials that we've been looking at in this collaborative, any one of those was really a problem because of that. We were unsuccessful on one single study that we were not able to get the data, but all of the rest of the data so far we've been able to get, or that people are promising as soon as they complete their specific sets of analyses that they've been doing, that they would be willing to share that with us. There are some mothballed data sets. That's been one of the difficulties too, in trying to get an old data set back up online and get the knowledge available for that too.
A follow-up. Did you have to get de-identified data sets, or were you able to get data sets that still had the identifiers in them?
Well, we did not get any identifiers in them.
That would be a way to address the IRB issue.
That's the main way, and the recent rule changes around IRBs of using de-identified data sets and not having to actually treat that as human subjects I think is going to be beneficial toward the future. Many of these have already been on IRBs that are not that way, though. The other part of it is trying to get data sets that we have a lot of treatment data sets as well, and so many of those are from pharmaceutical companies. Those have been a bit challenging to get, and they're not available for every antidepressant, for example.
Hello. How are you?
Good.
So I know you're all about the data, but I wanted to ask you let you have your say, I guess, in some kind of far-reaching questions. So they're not that tricky, but if you could, I guess, two audiences, if you could have, I guess the elevator pitch speech with the director of NIH about the next RFA that would be needed to really advance scientific equity, what would you want it to be called, and with the gaps, some of the gaps you identified in your work, what would you want it to be? And then the second part of that, if you go a little higher, if you were stuck in the elevator at the White House and thinking of affordable care and how that might play into our future interventions, what would you tell the president? So we'll elevate you to the head of NIH and president. What are those on those two levels? What would you want to say?
Let me say the second one first.
Okay, we'll start at the top.
Okay, start at the top.
Might as well.
There's a rule about that too. I honestly think that the knowledge base we're getting in doing research studies with efficacy and effectiveness is really important for us to learn. We learn about mediation and moderation there. Even if we learn those, I still think the major problems we have of dealing with health equity in our country have all to do with implementation. I would say that's way more than 50% of what we really need to do. And I think we are not concentrating seriously enough around what are the factors that allow communities and organizations, including healthcare organizations, to decide to implement. Why wouldn't you want to have parenting programs, for example, implemented and paid for by insurance companies? I think that would be a great opportunity for helping and improving the health of the United States. So that would be sort of a focus around that. And that's policy as much as science, and sort of some combination of that. I do think that there needs to be some careful look at what are we getting from the scientific side and making maximal use out of the data that we have already. So that's sort of the first part that you were looking at about the NIH world. I think we're not doing as well as we can in using the data that we've taken so much trouble to collect. And it's time to do that. I do think these kind of early stages of synthesis is one of the first steps in this. We're going to learn a lot more, and we're going to learn about where the important pieces are that we're going to be able to gain some material information from, and which ones are not going to be as useful.
So just following up, I mean, I'm Cheryl Boyce from NIDA, and we have a great secondary data analysis program announcement and some other institutes as well. But are you saying, I mean, do you think we have what is necessary really there, or are we missing out? Because usually the kind of stages you're talking about in terms of dissemination and implementation are separate. You know, it's a separate field, it's a separate study. So are you suggesting that, you know, we can build that on top of what we have? How do we put that all together?
I think I do think that there's a next step of conceptually of looking at the data we have and building a broader base of work on that. Now, it's like kind of the words big data kind of identify at NSF and office out of the president's office of trying to say, what can we learn from a social systems kind of approach, the way we've learned from bioinformatics. So it's really a knowledge informatics kind of problem in here. And I don't think we've really tackled it sufficiently well. Yeah. I think we're looking at small pieces at a time of combining 2 or 3 data sets together that are similar. We learned an awful lot about the methodology around that and some of the results, but I think it's now time to really look at that in the big picture. And I don't think we've really quite done this yet.
So putting more of a social systems informatics into the big data
I think that
framework.
The bigger context is probably where I think we could really make some big headway in here, much like bioinformatics has done, you know, with the genome and other big projects like that. I think there's real potential to be able to do that.
Now we just got to get you, you know, stuck in the elevator with them.
I'll be happy to.
Other questions? Well, thank you very much, Hendrik.